As anti-aging science advances from theory to therapy, a profound shift is poised to unfold in healthcare economics, the formal integration of longevity interventions into health insurance systems. What was once considered speculative, therapies to delay aging and extend health span, is now becoming an area of active clinical research and, increasingly, a matter of actuarial calculation. If the next generation of age-delaying treatments prove effective not only at enhancing quality of life, but at reducing the incidence of chronic diseases, then insurers and national health systems will have powerful incentives to cover them. This will mark a turning point in how aging is treated, not just as an inevitability to be managed, but as a modifiable condition to be prevented. The key inflection point will be clinical proof. If senolytics, for example, demonstrate consistent success in reducing hospitalizations due to frailty, cardiovascular disease, or pulmonary fibrosis in older adults, insurers will begin to view them not as optional enhancements, but as essential tools for keeping high-risk patients out of high-cost care. A single annual treatment that clears senescent cells could prove vastly cheaper than long-term medication for multiple age-related conditions, or extended stays in assisted living facilities. Similarly, regenerative medicine that reverses organ decline could postpone the need for transplants, dialysis, or advanced cardiac care, all of which carry massive costs. With that cost-benefit logic, insurers will begin to experiment. Some may introduce wellness riders that include longevity screenings, such as DNA methylation age tests or early inflammatory biomarkers. Others might offer reduced premiums to patients who adhere to evidence-based anti-aging protocols, analogous to today's incentives for non-smokers or gym attendants. Over time, tiered insurance models may emerge, where individuals at higher biological age, despite low chronological age, receive targeted interventions earlier, much like current risk stratification in cardiovascular care. Government-funded healthcare systems could be even more aggressive in adopting preventive aging therapies. Countries with single-payer systems have clearer financial incentives to invest in long-term health span extension, since they bear the lifetime costs of chronic care. If regenerative cell therapies or metabolic rejuvenation reduce the burden of dementia, arthritis, or falls in aging populations, national systems will increasingly justify the upfront expense. We may see public coverage of senolytic flushes every few years in the elderly, or inclusion of NAD+ precursors and telomerase activators in eldercare protocols, especially once long-term data proves safety and efficacy. Importantly, the insurance-driven adoption of anti-aging therapies will also catalyze innovation in diagnostics. Regular tracking of aging biomarkers such as epigenetic clocks, proteomic signatures, or mitochondrial function will likely become standard practice under these new models. Just as cholesterol and blood pressure monitoring revolutionized cardiovascular prevention, biologically informed aging scores will enable precise risk stratification and personalized intervention timing. Insurers may subsidize regular biomarker panels to optimize therapy scheduling and measure outcomes, creating a feedback loop of evidence-based longevity care. Still, the road to coverage will not be without obstacles. Regulatory frameworks currently lack a clear category for anti-aging claims, and therapies aimed at aging per se rather than disease states may face delays in approval. Moreover, the long timelines required to prove delayed onset of disease or mortality make clinical trials for longevity expensive and slow. To bridge this, insurance systems will likely rely on surrogate markers, such as improvements in frailty scores, cognitive function, or immune resilience, as early indicators of value. In parallel, real-world data from digital health platforms and wearable biosensors will help build the case for coverage by documenting population-level impacts. The broader societal effect could be transformational. Once covered by insurance, longevity therapies would become vastly more accessible, helping to democratize health span and reduce disparities. Aging could be addressed proactively across income levels, not just by those who can afford concierge medicine or boutique anti-aging clinics. Over time, this integration could reshape public health goals entirely, away from reactive treatment of illness towards systematic extension of robust, disease-free life. In the decades ahead, we can expect to see the emergence of what might be called the insured aging trajectory, a life pathway structured around regular checkups not only for disease, but for signs of accelerated biological aging, coupled with reimbursed interventions designed to delay decline. Anti-aging will not remain a luxury of the wealthy, but will evolve into a core component of preventive medicine, embedded into the rhythms of health coverage, tracked with precision, and justified by both compassion and cost. That vision is no longer distant. The moment insurers discover that longevity saves money is the moment it will become mainstream.